Going to start. So welcome. I'm happy to spend this evening just speaking about Pathway to Parenthood. So my name is Dr. McAvey. I am a double board certified OBGYN and reproductive endocrinologist and infertility doc at RMA of New York. I am specifically on Long Island. I run the Long Island practice, but RMA of New York is a historically Manhattan-based practice. We are the practice of Mount Sinai Hospital System, and we have offices and labs actually in not only Manhattan, but in Brooklyn and in Westchester. So I'm going to adjust this, and in Long Island, where I am. So I'm happy to engage in this conversation, and hopefully it's helpful to some of you who are listening or watching. I think that patients are very savvy and very smart in today's day, and put a lot of thought and purposeful effort when they are beginning to think about starting a family. There are many ways to build a family, and obviously it depends on your personal situation. If it's a male-female relationship, or if it's a single-sex relationship from the beginning. Obviously, the pathway looks very different, and for those couples, they obviously will always enlist a fertility doctor to assist with building their family. And same for a single female, so single mom by choice always typically needs to enlist either myself or one of my colleagues for assistance in building her family. For a male female, it's a bit different. Obviously most couples will likely try on their own for a bit before making an appointment to have a conversation and to have an evaluation. But I actually sometimes see patients who haven't tried to conceive and come into the office and really just want to check things out, or have a reproductive potential sort of done, prior to going forward with attempting to conceive. So meaning making sure that everything is okay before they go forward. And that typically would include genetic screening, so what we would call preconception genetic counseling, which genetics in general have, really evolved medicine, not just in reproduction, but also for cancer medicine. And so what I mean by that is, we all carry something as humans, cystic fibrosis, gene mutation, deafness, Tay-Sachs, thalassemia, sickle cell trait. And you always want to make sure that if it's, the egg source and the sperm source don't carry the same mutation, because if that were to happen, it's called shared carriers. And then that can lead to a certain percentage. Generally, if it's an autosomal recessive gene disorder, 25% chance of having an affected child. So for patients who are thinking about trying to conceive, sometimes we just draw the expanded carrier screening, the genetic screening, preconception before they go down that road. Again, being very purposeful and thoughtful about things that could come up. And so I think it depends on the couple. I think if it's, a young couple, specifically a young female, because women are built biologically very different than men. So if if it's a male-female couple and it's a young female, they don't need to do anything. I mean, they certainly could try on their own for a good 6 months before considering either seeing myself or one of the colleagues, or in the industry. But I also think it's completely fine to go in and have genetic screening done. Other things that get done depends on the personal history of the patient. So if you are a patient that has been told that you have uterine fibroids, for example, and you've been dealing with that since your late teens or early 20s, it's probably worth it maybe to have a sonogram just to get a baseline to see what the fibroid size are. Where are the fibroids? Is it something that we would be worried about in terms of the ability to conceive, or something that would increase, let's say, a miscarriage risk, right? So if you know that you have fibroids at baseline, maybe it is worth it to come in and do a sonogram. Other things that we think about: ovaries, so females, as I mentioned, are built biologically very different than men. And age of female is generally the biggest predictor of egg quantity and egg quality. There really is no good test for quality of egg, but we have very good tests to assess quantity of eggs, and younger patients typically have high quantities of eggs, whereas older patients typically have lower quantities of eggs. So again, on an evaluation with a fertility doctor, you could, same day, very easily see, what is the egg count or what is the egg quantity. And that is assessed two ways. One is with a sonogram that looks at a follicle count. So follicles are the structures that the eggs reside in. And so by doing a simple sonogram, you can say, okay, the ovaries are, decent looking inside in terms of volume, and there's a very good follicle count. That makes us very happy. Every once in a while, you'll see even a young patient in their late 20s, early 30s that have really low follicle counts, and it's very surprising to see that. But we're happy to see that because I think it does push the patient into trying to conceive sooner rather than later. And they might shorten the duration of attempting to conceive before, prior to going to a fertility doctor. So, by the textbook, especially if you talk to a general OBGYN, they would say, well, you're under 35, you can attempt to conceive for 12 months before going to see a fertility doctor. Well, maybe that wouldn't be the case if we knew that your egg count was low from the beginning. Maybe I'd say, all right, try on your own for 6 months, and if not pregnant, come see me, and then we'll maybe, go sort of move quicker into treatment, or, do something else that, we'll discuss. But, so, having information about quantity of eggs, uterus, genetics, I think it's very important. Metabolic things like thyroid function, sugar levels, weight, making sure, somebody is healthy, medically healthy, prior to attempting to conceive. Obviously, any sort of comorbidity, meaning a patient that has an autoimmune disorder, or Crohn's disease, or rheumatoid, there are all these new biologic treatments that patients are on. We want to make sure that those medications are safe to be on pre-pregnancy or pre-trying to conceive. And if not, working with the specialist that treats that particular medical disorder to alter or change the drugs. Psychiatric drugs, some are very, safe to be on, and some aren't. And so those things you really do, if you have some coexisting medical issue, you definitely want to think about it and have the conversation, should we change something or not, prior to getting pregnant. And then the other things that we think about, sperm, again, if it's a male-female relationship, sperm, so male health, history of the male. Is he on medications? Has he ever taken testosterone? Has he had surgeries on his groin, like a hernia repair? Was he born with an undescended testicle and, was told that he had a surgery to reset the testicles down? Those patients might want to have a sperm analysis or semen analysis performed as they're thinking about trying to conceive. Again, if the female patient is quite young, you certainly don't need to jump the gun and sort of ruin the fun of it. So, I would always encourage those who feel healthy and are healthy, and there's no existing health issues or medical issues or surgeries, to try on their own, because 80% of the time you'll get pregnant on your own. But if it's a male partner that, had, again, a significant health issue or medical issue or surgery, or was taking testosterone, or had something very significant like a prior cancer, you want to be cognizant of that. And sometimes we would check a semen analysis prior to having you go forward and try for a year. So a semen analysis will look at sperm count, sperm motility, and then something called morphology. So morphology is the way that the sperm looks under the microscope. Most men actually have very high percentages of abnormal morphology, so much so that the normal percentage is 4% normal forms, meaning 96% of sperm, if it's deemed to be structurally abnormal, it's actually normal. And so sometimes if we see that in advance, then it elicits a vitamin, or it elicits an ultrasound by a urologist, and we treat the male partner like a patient. So those are the things you generally think about. The last component of fertility is the fallopian tubes, which are the structures that allow the ovulated egg to enter travel to the uterus to then meet with the sperm source. Again, history that's important, history of chlamydia, a sexually transmitted infection, Crohn's disease, pelvic surgery, ruptured appendix, these sorts of things can lead endometriosis. It's a big one that we see, so patients that have been told, oh, you have endometriosis, painful periods, scarring in the pelvis, patients with, again, uterine fibroids, right? All these patients have increased risk of having blocked tubes. It's hard for patients when they go and try for 12 months and then they find out they have blocked tubes. They're not very happy, right? So it's sometimes nice to check the tubes, make sure the uterus looks good, make sure the egg count looks good, make sure the sperm count looks good, do genetic screening, check the thyroid, check the sugar. I also typically will check on the female immunities to things that we don't want you to acquire with a pregnancy. It can damage a developing baby or fetus, and that includes measles, rubella, and chickenpox or varicella. So those 3 diseases you want to be immune to in America. In the United States, those are required vaccines for entry into public school. So most people have had those vaccines. But every now and again, you'll see a patient that has what we call waning immunity, like they lost the immunity, they lost the antibodies to those. And again, it's nice to find out pre-pregnancy, oh, I'm not immune to measles anymore, I can't believe it. Then they get a booster for measles, which then will protect them through a pregnancy. The reason it's important to check is because you cannot get a measles or rubella or a chickenpox booster vaccine in pregnancy because it's a live virus. So, for patients that get pregnant on their own, the OBs check this. They get pregnant, they call the OB, they go in, and now the OB says, all right, you're non-immune to measles, obviously non-immune to chickenpox. If you hear of somebody that has shingles, okay, which is varicella, it exacerbates in older or immunocompromised individuals. If grandma has shingles and you are non-immune to varicella, you're not going to see grandma, right? So it's nice to know, the immunities of those 3 things. It's nice to know the genetics. And then again, whether or not you want to do some sort of evaluation for sperm and egg and uterus and tubes, I think is really dependent on female age and prior history of significance. So those are the things we think about. During an initial visit, if it's a male-female couple, obviously it's nice if both come in because we'll just draw bloods the same day to check for genetics. The female, same day, at least with myself, and I think most colleagues of mine, would have an ultrasound done same day. I always do it. You're here, let's just do it. So it's a transvaginal sonogram. We'll look at the uterus. I usually do a 3D sonogram to make sure the uterus is a nice size, looks good in terms of structure, that there's no uterine anomaly. And then we do a sonogram to look at the egg count. Bloods are drawn, for the things I mentioned. I didn't mention this, the other blood test that will look at egg count is a blood test called AMH or anti-Müllerian hormone, and it's just a marker of egg quantity. Sometimes the OBGYN send it. I think they're fairly comfortable sending it now, which is great because I have the result before you come in. It makes a bit easier. But if not, we can draw that. It's a blood test on the female. There are age-specific averages for AMH. In general, there's a slope. Young patients have high AMH, menopausal patients have 0. I'll sort of actually make it more like this. You're fairly stable in your 30s, and then it kind of dips a little bit like 36, and then the slope becomes more steep as you progress into the late 30s, early 40s. AMH is a tricky one though, because, and all of this is fairly tricky, but AMH in particular is tricky because for a patient who has not tried to conceive, if the AMH is found to be low, it doesn't necessarily mean you're infertile. You could have intercourse a month and get pregnant. For patients that are infertile, meaning cannot get pregnant on their own, have tried unsuccessfully, and now we find out the AMH is low. Well, that matters because fertility treatment outcomes are correlated to AMH levels. Typically the more eggs you have, the more successful you would be at let's say a fertility procedure like an egg retrieval or an IVF cycle. Not always, but often. So, if the AMH is low, naturally, again, I think it pushes patients into sort of a shorter time frame of attempting conception before then coming back to say, I haven't gotten pregnant, what should I do? And at that point, then we discuss treatment options. So, so the AMH level we would draw, day of the visit. Same with the sonogram, bloods to be drawn, and then we could always schedule a semen analysis that can, typically is produced at home and is dropped off here. Not a big deal. Produce at home, bring here within an hour or two, and we check it on actually a computerized system for the count and the motility, and then the morphology is done by a special lab technician called an andrologist. And so they're specialty trained lab techs that plate the sperm, stain the sperm, and then look under a microscope. And they really assess what percentage of the sperm looks structurally normal versus abnormal. So that is, the in-office evaluation, dropping off the sperm, and then the fallopian tubes, if one were to assess that, that would be done with an X-ray called a hysterosalpingogram, or an HSG is the abbreviated term. It is a functional X-ray. Either I do it or my colleagues can do it, or you can go to a radiology facility to have it done. It is fairly quick. It is typically done day 5 through 12 of your cycle. So once you're done bleeding and before you ovulate, and sometimes the natural conception rates and having that X-ray done is a bit higher. When I say it's a functional X-ray, I mean that a little bit of dye is pushed through the cervix. So it's a speculum exam, like when you have a pap smear at a GYN, gynecology doctor's office. Contrast is placed in, and then we can see on the X-ray whether or not the fallopian tubes are open. So that is, essentially the evaluation. And again, I think that age of female, medical history, GYN history, age of the man, medical history of the male is important on, determining whether you come in and have an evaluation or whether you just try on your own for 6 months. And then at that point, if unsuccessful, come into the office and be seen. For couples that are either single mom, single females by choice, or same sex, either female or obviously same sex male couples, they will seek our care immediately. And there's a process to that, having availability, having the availability to help patients in terms of securing either sperm sources, so donor sperm, or donor egg, is a lot of our practice. And, it is not as hard as it used to be. We have great access to sperm banks and actually to egg banks now. So most use of donor eggs is now frozen donor eggs, just like frozen donor sperm. So we can help guide couples into the best way to acquire sperm and egg. And then obviously for same-sex male couples, they also need a surrogate or a gestational surrogate to carry the pregnancy. And that is easier to be done in New York State as of 2021. And we have a lot of experience in coordinating and helping, in that process. So those couples end up coming in sooner rather than later. And then again, for the male-female, I would say for the male-female couple, for the female, see your GYN doctor. Most patients are very, good. They're vigilant about seeing their gynecologist for annual care. I always encourage that. We actually require it, prior to undergoing a fertility treatment. We want to make sure breast exam is good and that the pap smear is clear. Sometimes, we need to deal with certain things, and ideally prior to pregnancy, you don't want to be pregnant and then be managing something of concern. So, your general gynecologist is really a wonderful resource to start the conversation. Most of our practice, honestly, is from referring, OBGYN physicians that are in our communities. and we do rely on them for proper referrals. I do feel that patients, though, can certainly come in on their own. Patients are very, as I said in the beginning, smart and savvy today and really want to take control of their reproductive health, and their pathway going forward to parenthood. I really do get it. When you decide you want to be pregnant, you kind of, want it tomorrow. So um, it's important to know it doesn't happen every month. The natural conception rate, again, is age-based, but it can take up to a year to conceive, and that is within normal range. I do think a year is a long time, and I would say 6 months is a good juncture. If not, if unable to get pregnant, come in. Let's like very gently, gently start the evaluation. The evaluation process in and of itself can take 2 months. And then the other thing I just, sort of will mention is we are at a time where, um, you know, maybe you don't know when you would like to have a family. Or maybe you're not sure if you want to, but you're nervous not to have the ability in the future should you choose to. And that's a very different mindset than 20 years ago. So, which is amazing that we have this now. But, so thinking through that, there are some patients that I see who are very happily, in a relationship or married, and they're not sure of their timeline, for a million and one reasons, where they're living, their jobs, their careers, or maybe they're just out of a relationship and really are just taking time on their own. And so for those patients, it also is worth a visit. Maybe it is worth it to egg freeze or to preserve a fertility, or to embryo create and then go live, your best married life for 5 years and travel and come back when you want, and, use an embryo that we made when you were much younger, when it was much easier. And so that is called fertility preservation, right? So going through either an egg retrieval to freeze eggs, or going through an egg retrieval to fertilize eggs, make embryos, and freeze embryos. So, embryos and eggs can last endlessly. There's no expiration date. The technology is excellent. It has been FDA approved and standard globally since 2014. It is not changing. And most laboratories currently are very adept at thawing and using previously frozen eggs and embryos. And so again, being really purposeful and thoughtful about your life and your pathway, maybe it is worth it, to be seen and to do an evaluation, with the intention to potentially go forward and stimulate and, extract eggs or extract to create embryos in the future. So information is always, or knowledge is always very powerful. There's nothing wrong with having an evaluation, thinking about what when your timeline is going to be in terms of conceiving and starting a family. And so we are absolutely here to help and guide you, and to provide you with any information that you would like in terms of your egg, health, and your uterine health, your uterus health, and your sperm health, and your genetic screening. I think back to my own personal, I'm much older. And so, 20 years ago when I was thinking about having kids, we just, and I'm in the industry. I mean, we didn't think the way that we think today. Um, and, there can be regret with that, it just was a different time. So, use the technology that exists, use the information that is out there to help guide, in terms of, how long do you attempt to conceive, prior to coming in. So that is my little speech. I know there's a little Q&A box. You can drop questions if you wanted to, and then if not, I think the easiest way, to go forward, if interested in either speaking to myself, I could always do a telehealth, personally, with anybody, either, sort of with this platform. It's easier to come in though in person, but sometimes patients just want to do telehealth, and then we could always send you prescriptions to get labs and genetics done outside. Or you can certainly come in and see me. I see patients in Garden City on Long Island, which is right near Queens, but we have offices again in Manhattan, Brooklyn, and Westchester, and in other areas of Long Island. And, all the doctors are great, highly educated and well trained. And we are very happy to see and, help you during this process. If you would like to reach me, you can, I guess probably the easiest is just to go to the website, which is www.rmany.com. And you'll see all of the locations that are on there. There's a tab for Long Island, the Long Island section, and obviously you'll see my picture under there. Or just, you could always email the host who set up this podcast. So I wish everybody the best and good luck on your journey. And if you need anything, we are here to help.